Hi, everybody. Good afternoon. Thanks for joining us today. I hope that you all got the notice ahead of time that our meeting had changed till noon today. That was to help accommodate another great presenter. It's just one of the things we have to do to get you some of the best speakers. Let's see. So while the pandemic may be on its last legs, we still await notification of when we can return to the Stanford Burnham Press auditorium. Until then, we'll still continue with the live streaming on the third Saturday of each month. Please do pay attention to the emails that you do get from us in case we do have to change the day or change the time. But we will post it on the website and in emails ahead of time. Your hosts today are Bill Lewis, our new president, who also does the newsletter summaries, Jean Van Vliet, our director and treasurer, Steve Pendergast, our secretary and editor of the newsletter, Bill Manning, our director and videographer, myself, Aaron Lamb, director and facilitator, and John Tassi, our webmaster. And of course, there's all of you out there, 900 members over the years, and everyone is a volunteer. You can be too. As part of our support to you, we have our website, IPCSG.org. And that website has a wealth of information. In particular, there is access to all of our old newsletters, and those typically contain summaries of all of our meetings, as well as additional articles, up-to-date scientific articles to inform our members. You get those newsletters via email as well, as they're all there available from the website. And of course, there's the monthly video streaming on the third Saturday of each month. But perhaps one of the most important things that we offer to you is our hotline. That number there is the hotline. You can also find the number on the website, and that will put you in touch with one of our directors who can help answer your questions that you might have at any time, especially if you have recently been diagnosed and need some help coming up with information on what to do next. We do need volunteers. We need people to help recruit and schedule speakers. And of course, you can also spread the word of our website and meetings. We do look for people that are willing to share their experience, especially people with very recent treatment. We also need help taking hotline calls to help those other people that you were once of to get the information that they can need. So contact us either through the website or again through the hotline number. And we'd like you all to remember that our support group is based upon being a group that shares patient-focused experience on becoming your own case manager through informing, networking, and caring. We are a group of experienced participants, but we are not medical professionals. And any information that we share with you should not substitute for your own medical counsel. And we do need your support. We are a 501c3 nonprofit. Our donations are tax deductible, and we don't have any medical or religious affiliation. During the coronavirus pandemic, while we're video streaming the meetings, our costs do very much remain the same. So please do make a donation, either online via PayPal or sending a check to the address. Again, the address is available on the website as well. Our costs remain very much the same. We have some costs due to putting up the website, advertising, and yeah, those remain fixed throughout the year, whether we meet in person or not. So please do consider making a donation. Next month, we've set up a meeting with Jane Shellhouse. She's a nutrition and lifestyle strategist for all ages. And we haven't had a nutritionist in a while. I expect that a lot of you have some questions out there. I expect that to be an interesting meeting. However, for today, we have Justin Houman, Dr. Justin Houman of Tower Urology in Los Angeles. He'll be giving us a talk on the modern advances in men's sexual health. Dr. Houman is a urologist and fellowship-trained male reproductive medicine and surgery specialist whose practice is focused on men's health, including male hormone management, sexual and ejaculatory dysfunction, male fertility, male incontinence, and Peyronie's disease. Dr. Houman will be discussing men's health with respect to pre and post prostate cancer treatment. So with that, Dr. Houman, please take it away. Oh, I will add, Dr. Houman did say, please submit some questions throughout his presentation. Please use the Q&A pane for that. Any questions that he doesn't respond to during the presentation, we'll get to all of them at the end. And given that today's topic might be a little bit, people may be a little bit bashful to ask any questions, feel free to private message me. If the Q&A isn't able to, sorry, like train of thought. If you're not able to make the question anonymous through the Q&A, just private message me and I will relay the question to the group. Bill Lewis just mentioned to me that I made a mistake. Jane will be speaking on the 4th Saturday next month on the 28th, not on the 21st. All right, so with that, go ahead and take it away, Doctor.
Thank you so much, Aaron. Thank you for the introduction. Hey, good afternoon, everyone. My name is Justin Houman. I'm a urologist and men's health specialist here in Los Angeles, California. And I'll be giving a talk about the modern advances in men's sexual health, which is obviously a very important topic for all men, young and old. And given the fact that sexual health is so important to everybody, there's been a lot of advances over the last decade, specifically over the last few years. So it's an exciting time, and there's plenty of good options available for all men when it comes to their sexual health. So quickly about me, as I mentioned, I'm a urologist. I did my residency at Cedars-Sinai Medical Center. I did a fellowship. I took some extra time after my training to subspecialize in men's health, where I learned about men's sexual health, male infertility, hormonal management, specifically testosterone. And now I'm a practicing urologist at Tower Urology here in Los Angeles, right next to Cedars-Sinai. So when you think of men's sexual health, this is just a little overview of what it is. Aaron touched on this a little bit. So sexual health, when you think about it, it's any type of erectile dysfunction, ejaculatory dysfunction, libido issues, hormonal issues, Peyronie's disease. Peyronie's disease, when you have a bend in your penis, and I'll touch on that a little later. Reproductive health is infertility, a lot of vasectomies and vasectomy reversals. So why is sexual health important? A lot of guys ask this, and I mean it's important for many reasons. And a quote I like to use is, "Sex is like money; only too much of it is enough." It's one of those things that we all love. It's an important part of evolutionarily as humans, as animals in some way. We crave it, we need it. It provides us with good endorphins that make us feel good, and with that, quality of life is just improved when you have a good sexual quality of life. So there's very few doctors out there who talk to patients about this, because there's very few specialists in this. So there was a recent publication talks about 90% of men want to talk about sex with their doctors, but only about 20% of doctors feel specialized to talk about it. I've heard it all. I'll pay you $100 if you you can't make me blush. Things I've heard. So it's one of those things that feel free to ask any questions, especially at the end of this presentation. Feel free to ask anything. I feel like I've really heard it all, and there's nothing abnormal. There's nothing abnormal with having any type of sexual health issues. So feel free to talk at the end of this, or down the road. I'll give you my contact information and we could talk. So today's talk, we're going to talk about testosterone, erectile dysfunction, BPH, and finally Peyronie's disease. So we'll jump right into it with testosterone. Everyone knows what testosterone is, the male hormone, which makes us men. And it's very important to overall health. As we age, testosterone goes down, typically at the age of 30. 30 is our peak of testosterone. After that, 1% to 2% decline every single year. And some guys, they feel it's a faster decline. Some guys, it's more of a slower decline. How do you know you have low T? really there's two things to think of. Number one, the signs and the symptoms, and number two, there's a blood test. So subjectively, the signs and the symptoms, objectively, it's the blood test. So what are the signs? Low libido, low sex drive, fatigue, not being able to exercise the same way you used to, just having this brain fog, just mental clarity is not there like it used to be, not sleeping well, not eating well. A lot of guys complain about when they used to go to the gym, they used to be able to pump, or they used to be able to exercise for 45 minutes, an hour. Now, after about 15, 20 minutes, they're exhausted. They're done with it. Poor memory, poor focus. These are the real things when it comes to low testosterone. So this is a big component of it. The symptoms are the component of it. And then there's the diagnostic test with the blood work. So typically we say the range of testosterone is anywhere from 300 to 1,000, which is pretty broad. And this is the part that gets a little, this is the nuance or the art of what I do. Is the number only gives you a very, very small part of the picture. It's the symptoms, because this is the thing. It's my testosterone requirement is different than Aaron's testosterone requirement. It's different than the next guy's testosterone requirement. We all have if for me, maybe 400 is good for me. For the next guy, maybe 600 is good for him. So the number, it's important, but it's more the symptoms. If you're experiencing any of those or more than a few of those symptoms that we discussed, then at that point, I mean, we could consider you potentially being low T. We do need to get a blood test to confirm that, but you want to treat the symptoms. You don't want to treat the number. So why do testosterone levels decrease? As I mentioned, normal aging. The testicles produce testosterone. As we age, the testicles are no different than the heart, the lungs, the kidneys. The function of them slowly decline over time. So with that, your testicles produce less testosterone with age. In addition to that, we get weight gain. So why is weight gain so important? So we all have fat, and within those fat, within the fat, there's cells. It's enzymes called aromatase. So what aromatase does is it converts our testosterone to estrogen. All guys have some estrogen, not a lot, but when you get weight gain, more, because you're having more of those enzymes, more testosterone is converted to estrogen. Thus, testosterone levels go down. Poor sleep. There's a gland in the brain, the pituitary gland, that stimulates the testicles to produce testosterone. When you get a lax sleep, that gland is functioning at a much lower level. Therefore, the testicles are producing less testosterone. Stress, very similar fashion, that pituitary gland's decreasing. And then lifestyle factors, heavy drug use, alcohol use, those kinds of things decrease the function of that pituitary gland. Weight gain. So this is a study that was published. When you talk about, so let's say you want to naturally decrease or increase your testosterone levels. If you decrease your weight by 10%, you'll have an 85-point, if you increase your weight by 10%, you have an 85-point decrease in your testosterone levels, and vice versa. 15% decrease in your weight will lead to a 230-point increase in your testosterone. Sorry, that should say increase. But yeah, so anyways, decrease your weight by 10 to 15%, you're going to increase your testosterone levels anywhere from 85 to 230 points. So that's a good way of addressing it. Sleep, as we talked about, sleep apnea could cause it. Sleep deprivation could definitely cause it. And it's really the second half of your sleep. It's not so much the first half of your sleep, those last 4 hours of sleep. So it's anywhere from, let's say you're sleeping from 8 to 4. That time between 12 and 4, that's really when testosterone production is really, really happening. Your highest levels of testosterone are usually in the morning, right when you wake up. So some guys will say, wow, like I have, morning erections, I feel much more, my sex drive in the morning is much better. That's because your testosterone levels are so high. This one was an interesting thing where they looked at medical residents in the hospital. They compared, as you can imagine, medical residents are sleep deprived in many ways. So they looked at internal medicine residents' testosterone levels, and they compared it to everyone else who worked in the hospital. Medical residents were at 340 points. Everyone else was at 590 points. So almost double, 250-point difference. So that shows you the effect of sleep and stress and lifestyle factors on testosterone levels. When it comes to testosterone options, right, because low T is so common, there's so many options. It's all about frequency. There's daily gels. Come out of the shower every day, you apply gel. That's once a day. There's weekly injections. You inject into your subcutaneous fat or your muscle. And then there's some newer things where there's injections that last for 3 months. There's pellets, testosterone pellets that we place underneath the skin of your buttocks. Very small pellets that over the course of 3 months they slowly release testosterone, give you a good 3-month supply of testosterone. So it's all about what works for you. Whatever fits into your lifestyle. If you're okay with daily administration, weekly, or even every 3 months. So here you go, daily, weekly, or quarterly. These are some of the newer testosterone options. One of them is called Jatenzo. This is an oral one. You take it twice a day. This is much newer because usually the previous oral therapies for testosterone, they had some liver toxicity, not so much with this one. Zyosted, a lot of guys are averse to injections. They don't inject themselves. So this is an auto injector. All you do is you push it against the skin, and then it slowly releases the testosterone over 10 seconds, exactly where it should be, right into that subcutaneous fat, giving you a good steady blood level of testosterone for 1 to 2 weeks. The Testo, this is a newer one as well. This is actually intranasal testosterone. This is unique because one thing to note about testosterone is if you're taking synthetic testosterone, it's safe, and I'll talk about that. It's very safe. But what it could do is because it tells your body it tells your testicles to stop producing testosterone. Not only do the testicles stop producing testosterone, but they also stop producing sperm. Now, this is temporary. It's not permanent by any means, but it's temporary. So guys who are trying to have a kid, they should not be on testosterone. There's other options for that to increase your testosterone while preserving your fertility. And the Testo is very unique because it's a form of synthetic testosterone, but it maintains your fertility because you're doing it intranasally. Therefore, it gives you good boost in testosterone without compromising your fertility. So this is a much newer, unique therapy for guys. To the risks of testosterone, I know a lot of guys complain about, or a lot of people have worried about testosterone and heart disease. So essentially, I'm here to say it's the exact opposite in a lot of ways. So this was a study where if you look at this, if you compare guys with low T to normal T levels, essentially what happens is if you look at the survival here, if you look at the survival on the left, the graph, the guy with the normal testosterone levels is the guy with the blue, the guy with low testosterone levels is the guy in the green. As you can see, the cumulative survival over 8 years here is the guy with low testosterone has a 55% cumulative survival versus the guy with the normal testosterone about 75%. So we know now, we've done long-term studies on this. We know that now the guys who have low testosterone compared to that, a 55-year-old guy with low T compared to a 55-year-old guy with normal testosterone, that guy with low testosterone levels, he's increased risk of heart attack, increased risk of stroke, and he's more than likely to die younger. His overall survival is less. We know this. This is published data now. The reason why there's a lot of association with testosterone and mortality, cardiovascular risks, all these things that came out in the 90s was there was one study that was published that was very poorly done. It was the first one that came out. And when we went back, when you look at the data, it was completely done poorly. I mean, there was women in that study. It wasn't just men. They were looking at men, women. The way they analyzed the data was completely off. And there's been numerous studies since then that have debunked that previous study and have proven that testosterone helps you with your overall quality of life. And what I say about this is, if you take your testosterone, if you're low in testosterone and you go to, let's say, above 1,000, that's when there may be some risks. But if you're taking yourself to those normal levels, those 400, 500, 600, 700, that's where you want to be. That's where you want to be. That's when testosterone is safe, efficacious, will help you with good long-term survival. There's a question of testosterone and prostate cancer. So people think testosterone causes prostate cancer. Again, we're starting to learn that it has no effect on prostate cancer. If anyone's familiar, PSA, it's a antigen. It's a protein that's released by the prostate. It's a good marker for prostate cancer. It's not a great marker, but it's a good one. We do know that as PSA goes up, there's a chance of you're more than likely to have prostate cancer, right? So if you look here at these graphs, young men, older men, doesn't matter which graph you look at, as the testosterone increases, which is the blue one with the blue line, your PSA essentially stays the same. So there is no association between increasing your testosterone levels and PSA. We do know that now. And the idea behind that, without getting too scientific here, is that there's a prostate saturation model. If your testosterone is above 250, there's no increase in your PSA above that level. So essentially, back to what I just said earlier, testosterone does not lead to an increase in your PSA. And we could assume that because of that, it does not lead to an increased risk of prostate cancer. And I didn't put it in this, but we're actually finding out that there's some clinical studies going on at UT Southwestern, at MD Anderson Cancer Center, where guys who have metastatic prostate cancer, that's when it's spread to all parts of the body, they're actually giving them high doses of testosterone at various intervals, once weekly, once monthly. And they found out that the boost helps increase your immune system. And in doing so, your metastatic disease, that burden has actually decreased. It hasn't been published yet, but this is in the early stages of the study. So testosterone, again, prostate cancer, no association. Testosterone fertility, I talked about this earlier. It decreases your fertility. Synthetic testosterone decreases your fertility. So if you are interested in testosterone, if you are interested in fertility and you have low T, there's other things we could do. We could talk about that will naturally increase your testosterone levels without compromising fertility. So in summary here, when it comes to testosterone, no increased risk of heart attack or strokes, no convincing data that it causes prostate cancer, and it shouldn't be taken with men and with infertility. Now, moving on to the next topic, I'll address questions at the end if that's okay with everyone. Moving on to the next topic, erectile dysfunction, as anyone knows, incredibly common. 50% of guys before the age of 40 will experience some form of erectile dysfunction. Very common, very common. And with that, because of that, we have great options available. I always tell patients, I promise you some way, somehow, you will get a good, strong erection. It all depends on how aggressive you want to be. Reasons for low testosterone: vascular, hormonal, neurologic, as well as mental. There's a psychological component to all of this. As increased risk of, as you can imagine, with more likely those blood vessels that provide blood to the heart, as those constrict, that same reasoning why those blood vessels are constricting, it's constricting the blood vessels to the penis. Hence, erectile dysfunction is usually a first sign of heart disease. So I always like to make sure young patients who come in with erectile dysfunction get screened by a cardiologist just to make sure they're not having any, it's kind of like when check engine light comes on. That's what erectile dysfunction is, generally when you're younger. That's to that point. So 50% of guys before the age of 40 will experience some erectile dysfunction. So here's the good part. The options. Oral therapies, we all know the Viagra's, we all know the Cialis, works for about 78% of guys. And some guys, this is what they live off of their entire lives. They're okay with this. It gives them a good, pleasurable, satisfying erection. And you could get this. These are generic now. You can pretty much get them online without even seeing a doctor in person. So these work great. They work wonderful. There's gels this is slightly more invasive. So for those 20 to 30% of guys that the oral therapies don't work for, you could put, as you can see here on the upper right, there's gels that you could put into the urethra. There's suppositories that directly act at the erectile bodies, and they really help engorge the penis. Guys love this. I'd say about 60% of guys, they swear by this. They say it's the best thing. About 40% of guys say it doesn't really work for them. So you have to move on to another option. What are the other options? This is intracavernosal therapy. So if you could see here from the picture on the right again, this is when you inject directly into the penis. It's a tiny, tiny syringe, a tiny, tiny needle. Once you break the taboo of injecting yourself with a needle, it's very good. I mean, I have patients who are on this, who have been on this for 10, 15, 20 years, and they love it. There are some risks associated with it, obviously. The more you use it, you could potentially scar the penis down. But this is a great option for a lot of guys that really gives you a rock hard erection. And like I said, it's a tiny, tiny needle. It's an insulin syringe, so you don't really feel much. But I do understand the taboo of injecting your penis with a needle. It could be, I think most guys would be a little shy to do that. And the gold standard of what we have now is the inflatable penile prosthesis. So this is a surgical procedure. It's essentially you have an implant completely underneath the skin. I do a lot of these surgeries, maybe 1 to 2 of them a week. And essentially what happens is you have a cylinder in the penis, you have a pump in the scrotum in between the testicles, and then you have a reservoir that sits in the lower abdomen. So there's the fluids in the reservoir. Every time you want to have an erection, you squeeze that pump that's in the scrotum, kind of like remember the Reebok pumps back in the 90s? So every time you want to have an erection, you squeeze that pump, the fluid goes from the reservoir into the cylinders, and it gives you a super strong erection. It doesn't compromise anything in terms of ejaculation, orgasm, pleasurable sensation, because the incision is usually made right here in the lower part of the penis or lower part of the scrotum. The nerves and everything are on the upper part of the penis. So guys love this. I'd say, I say here 90%. I think it's actually like 95 or 96% of guys report excellent. They're very satisfied after this. The recovery is relatively short, a couple weeks, and you should be able to start having sex anywhere from 4 to 6 weeks after the implant goes in. This is kind of a timeline of what, the oral therapies, there's always a new therapy coming out because erectile dysfunction is so common. Talking about the modern advances, these are the newer therapies for this. Shockwave therapy, this is a wonderful option for a lot of guys. Essentially what it is high energy sound waves that stimulate blood vessel growth within the penis. And what's an erection? It's blood vessels, right? So the more blood vessels you have, more blood comes in, gives you a stronger erection. This, if you asked me 18 months ago, I would have said anecdotally, guys love this, and the outcomes are good. Now we have a lot of good science. We've published studies on this. There's good scientific data supporting the use of shockwave therapy. Insurance companies haven't approved. They're not covering it quite yet. So generally, it costs anywhere from $2,000 to $4,000 for the whole treatment cycle. It's usually six treatment cycles, or 6 treatments, excuse me. But it works great. It's not immediate, but over the course of months, those new blood vessels come into the penis, and as a result of that, you get a good, strong engorgement of the penis and a harder erection. This is the science behind it. Essentially, a shockwave, high energy sound waves, like I said, growth factors leading to new blood vessel growth. We used to use this for kidney stones, and now we use it for the penis. So it's something we're very familiar with as urologists. And it's used in other medical fields as well now. Plantar fasciitis, new blood vessel growth to that area could decrease the inflammation, Achilles tendonitis. And now they're even using it in cardiac patients. Guys who have had heart attacks, they lack that blood vessel growth to certain parts of the heart. So by doing this shockwave therapy, you're stimulating neovascularizations of different parts of the heart. And as a result of that myocardium, the muscles of the heart, are getting revascularized and essentially starting to pump better. This is kind of shows what it is. Like I said, high energy sound waves. Now, the next thing is P-shot. This is platelet-rich plasma. Athletes are doing this now into their joints. I think Kobe was the first one who popularized this. Essentially, you're taking the richest part of your blood, you're spinning it, you're centrifuging it, taking out that plasma, which has a ton of growth factors in it, and we inject it into the penis. I would never say to do this by itself. I would always say do this in conjunction with something else, whether it's the shockwave therapy, whether it's taking oral therapies, injection therapies, what have you. But this is a good long-term. It's kind of like the shockwave therapy and the P-shot are big long-term. Essentially, they're penile rejuvenation. They help restore. They help take you back chronologically in terms of your penile health. But it works. This works. We don't have scientific data supporting this quite yet. We're still gathering that. But anecdotally, again, it works. To be honest, it works to a lesser extent than the shockwave therapy. But some patients have had amazing responses with this. We're still trying to figure out which patients this works best for. Erectile dysfunction in review here. Incredibly common. A lot of treatment options available. And then again, I'll say this. If you want an erection, a strong erection, I promise you, we'll give you that some way, somehow. It just depends on how aggressive you want to be. If you want to do the injections, if you want to do the surgery, if you want to do the P-shot, shockwave, what have you. But we'll figure out, we'll get you a good erection. That's not a problem. BPH, enlarged prostate. I think most guys are familiar with this. Typical symptoms: waking up at nighttime to urinate, you're not emptying your bladder, weak stream, dribbling. You feel like your urine is dribbling. It's not really coming out at the same way it did back in the day. Everyone's favorite part of going to the urologist, you do a digital rectal exam. As you can see where the finger is relative to the prostate, where the rectum is relative to the prostate. You feel it. You get a good sense of the size of the prostate. There's different things we could do for this. Oral therapies generally work. I'd say for about 90% of guys, the oral therapies work for. They open up the prostate, they shrink the prostate, overall leading to a more open channel. If that doesn't work, we consider various surgeries. This is the Roto-Rooter procedure where we go in there, we go into the prostate and we core out that channel where the urine streams through. We core it out, we open it up, and essentially the bladder is really able to empty. We've been doing this for decades now. It's a great option for a lot of patients. Relatively straightforward surgery. Typically you stay one night, but sometimes patients go home the same day, but great option for a lot of patients. Here's a video of it, as you can see here. So that's the prostate. This is the loop. That's the loop, and we essentially cauterize it. So you just, as you can see here, you're pulling back that loop with a hot knife, and you're just taking out that tissue. You're cutting out that tissue, and you go around the whole prostate. You just go in a loop around that prostate. If your channel is like this, by the end of the case, your channel is wide open. Some of the newer therapies, so obviously that's a surgery, and as medicine becomes more and more advanced, we're doing things in the office. We're doing a lot more things in the office. So Resume is one thing we do in the office. So here, what it is if this is a camera that we're putting in the urethra, and this gland here, as you can see, this yellow gland is the prostate. What Resume is we're injecting water vapor, high temperature, high steam essentially into the prostate. We numb you up so you don't really feel anything, but we inject steam, into the prostate, and over the course of days to weeks, that prostate tissue will slowly die off. And with that dying off, that channel opens up. Great option for a lot of guys. They go home right there and then. Catheter may have to stay in for a day or two after the procedure, but otherwise you're able to go home. This is the machine. The procedure itself takes about, I don't know, maybe 90 seconds. But yeah, like I said, this is a good new advance in terms of BPH treatment. There's something called the UroLift as well. So similar to the Resume, we put a camera in there, and rather than putting water vapor into the prostate, we're stapling the prostate open. We're essentially putting in a staple. Doesn't hurt because your prostate's numb. We numb you up. It pulls those lobes of the prostate, that channel, essentially staples it open. This has been out for a few years. Guys love this as well. In-office procedure, you go home the same day. It works great. This kind of goes over what it is. Prostate artery embolization. This is something new that we're doing as well. So essentially, we go into your arterial system through a small catheter through your groin. We go into your arterial system and we embolize. It's actually the interventional radiologists do this, but essentially you're stopping the blood flow to the prostate. And over the course of this takes a little bit longer, but over the course of months, the prostate shrinks in size. And as a result of that, that channel opens up. I would say this is more for patients who are poor surgical candidates or they don't want to do anything in the office. This is kind of a last line, but it is something we're doing now, and some patients prefer to have this done. Here you go. In review, BPH is something we're all going to experience as men. And as we're advancing more and more, there's better and less invasive options available, not surgery, not anesthesia. So you can go home right there in the office, and it's just as efficacious as surgery used to be. Finally, Peyronie's disease. Now, I don't know how many people are familiar with Peyronie's disease, but Peyronie's disease is now, we're learning a lot more about this. There's a lot of there's companies out there who are really pushing this. I don't know if you've seen these commercials during the All-Star game, during the MLB games, baseball games. Having a crooked penis, to a certain extent, is normal. Nobody's penis is perfectly straight, right? Not a single person. However, there's sometimes pathologic curvature where the curvature is something that develops over the course of your lifetime. There's pain associated with it. It's so curved that you're unable to have penetrative intercourse. Sometimes guys will come in with 60, 70, 90-degree bends in their penises. And as you can imagine, you can't really insert, right? You can't do much. You can't even masturbate with that. So decades, for the last 2-3 decades, what have we been doing? Oral therapies. We try to give you medications that can help dissolve a plaque. So the way to think about Peyronie's is if the penis is a balloon, the Peyronie's plaque is like a piece of duct tape on that balloon. So if that balloon expands, That piece of duct tape won't. So the whole thing will expand. However, that portion, that plaque will not. And we're learning more and more about this. There's a huge genetic component to it. Guys of generally Northern European ancestry, Vikings, they have Viking lineage there. They have this a lot. A lot of guys who have Peyronie's disease, they also have plaques on their hands. We call these depoutrance contractures. So John Elway, the Broncos quarterback, he's well known for this. As he's aged, he's unable to fully extend his hand now because he has a depoutrance contracture. He doesn't have Peyronie's, but he has this. So he's unable to extend that finger. So these plaques develop on your certain parts of your body, including the tendons of the hand and the we call it the tunica of the penis. So what do we do for this? The plaque is collagen. It's essentially a form of collagen on there. So what do? We inject you. This is a great treatment that came out probably 10 years ago. It's great. It really, really works great. It's called Xiaflex, Xiflex. It's collagenase. You inject the plaque with the enzyme, and over time, it's essentially 8 injections over 18 weeks. Over that time, that plaque will slowly soften up, and as a result of that, that penis will really straighten out. Generally, we say you'll get at least a 50 to 60% improvement, not a degree improvement, but a percent improvement. And that usually puts the guy at a great point where they're able to have good penetrative intercourse. Again, no penis is perfectly straight. So that in itself does the job. So there's before, there's after. That concludes my talk. There's a little bit more information about who I am, what I do. If you take a picture of this, it has my information on there. You could save it onto your phone. It has my office contact information. And here's my office contact information down there as well. Feel free to reach out if you have any questions.
There are already a couple of questions on the Q&A. Can you see those? Would you like to address those?
Oh, here.
But,
here we go.
Okay.
Yeah. So following a prostatectomy, I was using Tri and Biomix for ED, and it worked. Several months after starting ADT using Firmagon. Is this direct from it? So the question is essentially, someone had a prostatectomy, they start to inject with that injecting into the penis for erectile function. And then as sometimes after the prostatectomy, you have to be on a therapy that decreases your testosterone levels until as part of the therapy afterwards. So the question is, are his poor erections now a result of the ADT? And the answer is yes. Yes. So you need testosterone to have an erection. Now, can you increase the Bimix or Trimix dose in order to overcome that? Sometimes yes, sometimes no. But that's why a lot of times in this situation, guys will go ahead with the penile prosthesis because you could overcome that. You could overcome that that lack of blood flow, because this essentially will give you the ability to have a good, strong erection on demand whenever you want. The next question is, if there's no association between T and prostate cancer, why do you use ADT for prostate cancer? Great question. Okay, so like I said, so we do know that to a certain threshold, under 250 for testosterone, there's a correlation between testosterone and PSA. Above that, there's no correlation. So when you have metastatic, so when you have localized prostate cancer, you don't have to do any ADT. But however, when you have metastatic prostate cancer, you do have to decrease the testosterone in order to kill or to decrease the nutrients for the prostate cancer cells. So it's generally more in the metastatic or locally advanced prostate cancer, not so much for the local. The next question is, are there therapies for men who are not erectile dysfunction? Who are not erectile dysfunction, but who no longer experience a significant orgasm? Yes. So, so the question, I'll read it again. Are there any therapies for men who are not experiencing erectile dysfunction, but who no longer experience a significant orgasm? Yes. So those two kind of go hand in hand, kind of, in the sense that if you think about an erection like a think of it like a guitar, right? If the strings are very loose, you're not going to make a good, strong sound. However, the tighter the strings are, you can make a stronger, more resonant sound. So a lot of times, guys, your erections may be 70%, which may be good, but it doesn't trigger all those nerves that you need to stimulate a strong orgasm. So sometimes by increasing the strength of your erection from 70% to 90%, you're able to trigger many more nerves, and as a result of that, your orgasm becomes a hell of a lot stronger. So yeah, there is ways we could address that. Absolutely.
I have a number of questions myself that I can add. However, I wanted to jump in on the first question that was asked about the trimix and bimix, to mention that I actually was on bimix after my surgery. I tried it about, I think, 4 months afterwards. And one of the things that the doctor said to me was that it's just not magically going to, give you an erection. You still have to go through the psychological part of being turned on and so forth. Over the course of I guess 1 year year and a half that I used the injections, I was on ADT for almost all that time. In fact, I take it back. I did start ADT prior to using the injections. And I had mixed results, maybe 10 to 20% of the time there was no effect whatsoever, but, also probably 25% of the time I was using an ice pack and Sudafed to try to make the erection go down, because it was been 3 hours and the next stop was to go to the emergency room. Perhaps I have actually heard that some doctors provide basically the antidote to inject as well. Is that something that you recommend doing?
Yeah, I mean, if you're comfortable injecting, so, some patients, I give them a little bit of the antidote, I mean, just because they have experience with it. But very rarely, to be honest with you. The only reason is this, it's because there's side effects associated with the antidote. Because what happens is it's phenylephrine, right? And what it does is it could cause cardiac issues. You have to do it in a very monitored setting. You want to check their heart rate, you want to check their pulse, or their blood pressure, excuse me. So if that's the case, generally you want to recommend they go to the emergency room where they're able to get that injection in a monitored setting.
Gotcha. Interesting. After my surgery, I actually was a little bit disappointed that my surgeon did not address erectile dysfunction directly, given that I guess there have been, I guess more recently than not, Cialis gets prescribed soon after a surgery, just to help with rebuilding the blood flow to the area. Can you tell us a little bit about what your thoughts are on the use of Cialis immediately after radical prostatectomy?
Yeah, I'm a big fan. I actually put patients on it even before.
Interesting.
Yeah. I put patients on it before because the idea is this: is the penis is one of those organs. If you don't use it, you lose it, right? It really is, in the sense that throughout, when you're young, you're getting erections 4 or 5 times a night. You're getting that blood flow to the penis. It's giving that tissue, nutrients, oxygen, everything it needs to survive. Now, after you undergo a prostatectomy, those nerves, sometimes they're cut and you're not able to have a spontaneous erection ever again. But even if those nerves aren't cut, they're after surgery, they may not function the same way they used to temporarily, right? So you're not getting those erections at night. So what happened is, I noticed this a lot, is the guys would come in after 6 months, like, all right, after 6 months after prostatectomy, they're like, look, my erections are strong now, but my penis is a lot smaller than it was before. Why is that? And that's because the penis was scarring down, right? It didn't get that blood flow over those 3-6 months. And as a result of that, that scar tissue contracted it just enough in girth and in length where it became noticeable. So I give you guys Cialis daily, every single day, actually. A couple of weeks before prostatectomy and definitely after. And what it does, it just maintains that blood flow to the penis. It's not necessarily to give you like a full-on hard erection, so you're able to go out there and have a lot of penetrative intercourse, but just enough so you're getting those erections at night, just enough to give your penis enough blood flow so it doesn't scar down.
Gotcha. And I also recall that the Cialis also would not work unless you actually had testosterone in your body. Is that correct?
Yes, and yeah, when you're on ADT, it's hard to have a natural spontaneous erection. Yeah, it's very hard. So yeah.
Gotcha. Let's see. I think there's another question that came in. Oh, no, I'm sorry. Those were the same questions as before. Yeah, I was glad that you said preemptively to provide Cialis before treatment, because there was a very little that was done for me prior to surgery or radiation or ADT. I guess you did mention starting Cialis ahead of time. Do you recommend any other things such as, or even afterwards? What are your thoughts on pelvic physical therapy?
Yeah, pelvic floor physical therapy is good. I wouldn't start it. I mean, the thing is this: it's the idea of to your point about pelvic floor physical therapy. Are you asking from a urinary incontinence standpoint?
Well, both that as well as sexual
Yeah.
standpoint.
Um, so we're still trying to figure out pelvic floor physical therapy is actually really good for erectile dysfunction. It seems like it's only for mild forms. And the thing is this, it's in the post-prostatectomy setting, it's probably not going to help your erections. It may help with your urinary incontinence. And so this is what I'll say is the best thing you could do for yourself before prostatectomy is Kegel exercises, right? And generally I say do 10 sets of 4. Kegel exercises just strengthen your pelvic floor, and you're just doing that at home by yourself. And that works great for a lot of guys. But the incidence of urinary incontinence has gone down so much after with prostatectomies, because now we use the robot. And what the robot does is it gives us direct visualization of that sphincter. Back in the day, we were looking at it from afar in some ways, and that sphincter, you're able to take some of those muscle fibers of the sphincter, and they have some levels of incontinence. But nowadays, it's so rare to have incontinence with the robot out. So that's why Kegel exercises are great. Now, if Kegel exercises don't work, then pelvic floor physical therapy is a wonderful option. Yes, but I would do Kegel exercise before I jump to that.
Great. With your experience of patients that have had prostate cancer and have treatment, do you typically see fewer sexual side effects in patients that have received one type of treatment versus another? For example, surgery versus external radiation and brachytherapy. What from the sexual standpoint, what is the best therapy to pursue?
So it also depends on your so if your prostate cancer is localized to the prostate, you have those 3 options: brachytherapy, external beam radiation, or prostatectomy. I would go with a prostatectomy. Reason being is because brachytherapy, there's a chance of a collateral damage because you're not really controlling the spread. External beam radiation, same thing. You have some control, but it's not perfect. Surgery, you're actually able to go in there. We're able to see those nerves, and we're able to peel those nerves off. We know when we're cutting nerves and when we're not. If there's any evidence of tumor, of prostate cancer going into the nerves, we know that we're cutting a portion of that nerves in order to take that prostate cancer out. So it's very exact. A prostatectomy is very exact. Surgery is very exact. External beam radiation and brachytherapy, they're good and they're very precise, but there's a chance. It's the chance of it causing collateral damage to the nerves of your erections are slightly higher.
Interesting. Yeah, I'd forgotten about that fact about it. What was I going to ask about that? Oh, shoot. Nuts. Well, maybe I'll remember in a minute. I guess one thing I was going to mention is that, well, with surgery, you're pretty much guaranteed to lose about 1 inch, 1.5 inches of the length. You wouldn't have that with the radiation, though, correct? Or do you also start to see some reduction in size just basically by what you said? Like if you're not getting erections, then eventually over time it is going to atrophy.
Yeah, the one thing about surgery is if you think about it, the way our anatomy, you have the bladder, and then there's a small part with a prostate, and then your urethra, your penis. So the prostate's coming out. So the bladder usually advances just enough where it could attach to the urethra. Just because the bladder drops, gravity will pull the bladder down. Now, sometimes the urethra has to get retracted just a little bit to span that gap. So there is in some patients, there's some penile shortening, but it's not significant in terms of like your penis actually going into the body. The bigger complaint is what I talked about with it scarring, with a penile scarring. You're not getting blood flow for months. And because of that, the penis shrinks in girth and in length, both.
Gotcha. Let's see. How about thoughts on low testosterone's, especially during ADT's effect on bone density? Is there anything that you recommend post ADT for helping with bone density issues, or even during ADT?
Yeah, I mean, vitamin D and calcium, generally vitamin D and calcium. But the one thing about calcium is you have to make sure before you start doing that, you want to make sure you get there's a scan that you could do to see if there, the calcification levels within your heart or within your blood vessels, to the coronary arteries. So I wouldn't say just willy-nilly start taking vitamin D and calcium. Make sure it's okay, because usually there is a scan that needs to be done prior to that. But yeah, testosterone is huge when it comes to bone density. So you do have to, there's certain things you want to do to supplement, to prevent that decay in bone density.
Gotcha. That's curious that you mentioned that you said calcification within the heart muscle itself, or just arteries in general?
Yeah, arteries.
Arteries. Because when I had my biopsy, the doctor was surprised at the level of calcification, he said, in the prostate. Do you know if that might be an indication of calcification elsewhere in arteries?
Yeah, that's different. Calcifications in the prostate, what it usually means is it's a gland. The prostate's a gland, and it's always producing those juices. The juices, the prostate secretes juices that help the sperm in the vagina. That's the whole point of the prostate. The calcifications of the prostate happen because portions of that gland aren't getting that juice, essentially the products, out. So they sit there, and over the course of time, those pockets calcify.
Gotcha.
So it's not related to calcifications in the heart. It's a little bit different.
Gotcha. Okay. Let's see. I have another question too, heading a little bit more closer to home. So when I was able to resume intercourse, I started having like a burning sensation after orgasm in basically the end of the shaft of the penis, and it would occur for like, maybe a few seconds, might not be too painful or whatever, but it could last 30 seconds and be quite painful, like a burning feeling. My urologist had said, like, it's not any kind of infection. He felt that it was due to remnants of the seminal vesicles still being, not having been fully removed. And I don't have a complete explanation from him as to why that would cause the pain. He thought it was some type of referred pain. Maybe if it was still trying, something there was trying to pump fluid that couldn't go anywhere. Fluid's incompressible, can cause a problem. But are you familiar with anything like that?
Where is the pain exactly?
I feel the pain in the end of the penis, towards the tip of the penis. And it might burn for 5 seconds, might burn for 30 seconds. Urination doesn't make it go away. It's only just after orgasm.
Yeah. Interesting. I mean, it's the pelvic floor triggering. So typically that happens when you don't have a prostate anymore, correct?
No, I do not.
Yeah. So that's typically prostatitis pain, as I'm sure someone told you. That's the pain you get. So it must be that the pelvic floor is triggering some of those nerves that used to be around the prostate. Yeah. How long has it been?
I had the prostate out 4 years ago, and I was stage 4. So I quickly went on to ADT for 2 years and had external beam radiation.
Wow. Is it getting any better?
It was bad about 6 to 9 months ago, approximately the time I got married. And it's kind of come and gone since then, but it's still there.
Yeah, one thing you could try is you could try taking an anti-inflammatory, like a prescription strength anti-inflammatory, because the thing is, it's just inflammation. You could take an anti-inflammatory for 3-4 weeks, and the hope is that it just kills the inflammation in that area, and it's going to do one of two things. It's going to help address the pain, that's for sure. But the question is the inflammation going to come back? I wonder. I mean, but it's worth a shot. As long as your kidney function's okay, it's worth a shot.
I should have mentioned actually that he had put me on Flomax for 3 months, but I didn't seem to feel much difference in the pain level when that occurred. Now, is Flomax a type of anti-inflammatory, or are you referring
No,
to taking ibuprofen?
Flomax helps open up the prostate. He put you on Flomax after the prostatectomy.
Yeah.
Interesting. Yeah, I mean, it could work. It could work. But there's an anti-inflammatory called meloxicam that works pretty well.
How do you spell that?
It's Mobic, MOBIC.
Okay. Sounds good. I will give that a try when I see him, or I'll ask him about it when I see him this week.
Yeah.
Is that a over the counter or?
No, it's prescription.
By prescription. Okay. Excellent.
Yeah.
Doctor, I thank you so much for your time. You're doing great work for helping a lot of men, and it's really, really important to us all, even if we don't talk about it. So
yeah, of course. I hope this was informational. If you have any questions, feel free to reach out. There's my contact information. You guys could see it.
Yeah. Yes. Excellent. And we'll post that phone number on the website as well, and address too.
Perfect.
Thank you so much for your time.
Thank you, everyone. Have a great rest of the weekend.
All right. See you, everyone. Bye-bye.
Take care.